Actually, it was during the trial that he came to my office follow up and was in tears because he was like, I will shake hands with you today. And I have been cooking using this hand.
The podcast is for information, education, and entertainment purposes only. This applies to all information, graphics, videos, and content on the affiliated website and podcasts. The aforementioned does not constitute medical advice, nor does it establish any patient-physician relationship. The information and content on this website do not substitute for any professional medical diagnoses, treatment, or advice. Seek advice from a qualified healthcare practitioner for any questions you have concerning a medical issue, including treatment. Do not delay consultation with a professional or disregard their advice based on the information on this website or podcast. The opinions, statements, and views are that of my own and do not reflect those of my affiliated institutions, policy, or any entity.
Hello and welcome to World of Pain MD podcast, where we discuss all things pain with the experts. I'm Dr. Derek Davis, a physician who is subspecializing in pain management. In this episode, we speak about peripheral nerve stimulators with Dr. Vinita Singh. Dr. Singh is double board certified in anesthesiology and pain medicine. She went to medical school at Armed Forces Medical College in India, did residency at Indiana University School of Medicine, then fellowship at Emory University. Dr. Singh is equal parts brilliant and positive energy. I'm very happy I was able to speak to her about this topic. Peripheral nerve stimulators is not a new technology, but we have seen it become more and more popular in the pain space, especially as we moved away from treating pain with opioids. Though their mechanism of action is not completely understood, they work by much the same way as a TINS unit. In essence, stimulating one nerve fiber to block a pain signal of another. We discussed them in further detail with Dr. Singh, along with her approach to using them. As always, thank you so much for watching or listening. I hope you enjoyed this episode and learned something. Dr. Singh, thank you so much for being on the show. Welcome to World of Pain MD. I appreciate your time.
Thank you for having me here.
So we'll just get started and jump right into things. So we're talking about peripheral nerve stimulators today, otherwise known as PNS. So, I think it goes back all the way to the 1800s, and we have spinal cord stimulators. But how would you explain peripheral nerve stimulators, that how they work, and then how they're different than spinal cord stimulators?
So peripheral nerve stimulators have really expanded our toolbox much beyond spinal cord stimulators. And spinal cord stimulators, as you know, is a method of changing the pain signal to some other signal or no signal in the spinal cord level. With the peripheral nerve stimulators, we're able to target much finer and much distal, closer to where the pain is. And therefore, it's more targeted therapy, and we're able to change the pain signal to no signal or some other signal. And I have found that it also works in cases when the primary problem is not nerve related. Mm-hmm. It just happens to be the nerve that's carrying the pain signal because you are so focused and targeted. Mm-hmm. So overall, it has just expanded our toolbox tremendously.
So what sort of conditions or symptoms are you kind of cueing into that you would use a peripheral nerve stimulator for?
So whenever you have pain that is distributed in 1 to 2 nerve distribution, limited pain, that is harder to treat otherwise, and you may not have any other options to treat, or you have failed your conservative management, mm-hmm. which includes your complementary therapies, physical therapy, and usual medications mm-hmm. for pain, then you can target the peripheral nerve stimulators. One neat thing that has become available about peripheral nerve stimulators is the peripheral nerve stimulators that can be percutaneously placed, mm-hmm. and therefore you have their energy source, the battery that is being worn outside, mm-hmm. And the pulse generator sometimes is part of the battery or sometimes part of the lead, the wire itself. So that really increases where you can place it, because you only have to plan placing the wire, and you mm-hmm. don't have to think about placing the battery, as opposed to a decade ago that was not an option. So you had to be very careful in planning which nerves you can target, because you have to also plan for that bigger battery that you have to place under the skin. Whereas in this case, if you're able to do a nerve block, almost always you're able to do a peripheral nerve stimulator in that area.
So did people used to like cut down to the nerve to put?
Oh, yes, absolutely. Yes, neurosurgeons would do it. They used to be actually cuff electrodes for peripheral nerve stimulators, or using off-label spinal cord stimulators for peripheral nerves.
And so using off-label spinal cord stimulators, like how is that system different than what we have as peripheral nerve stimulators as we know them today? Like, were they bigger, like bigger systems, bigger electrodes, leads?
So I think, there are all kinds of peripheral nerve stimulators available on the market now, right? So we have temporary 60-day peripheral nerve stimulators that are hair thin wire, and the programming options that you have with that wire is a little bit different, because how does the electricity reach to the target, and how does the loop close is a little bit different. What is plus, where is the plus minus target? And you have limited ways you can program that, how many frequencies you can do it, 200 or 12 hertz for your motor, 200 for nerve. And then you also have other kinds of peripheral nerve stimulators who are, again, shorter, but can be permanently implanted, but a little bit limited on what kind of programming you achieve with that, and how does the electrical circuit complete. And there are also options that almost look like a spinal cord stimulator lead, but the spinal cord stimulator usually has 8 contacts, and the peripheral nerve stimulators have limited 4 contacts, because you're really not trying to, your target is very finite, and you don't need that big bandwidth. So it depends on which one you're using. The electrode itself can be very similar, looking like spinal cord stimulator in length and width. But the biggest difference is really the battery, where if you're using off-label spinal cord stimulator electrode, then you're putting the battery under the skin, and that's a bigger footprint inside the body, as opposed to if you're using one of the modern peripheral nerve stimulators, then it's over the skin.
Got it. Okay. So you kind of mentioned this already, when someone's failed conservative treatment, physical therapy, medications, but where in your algorithm of treatment do you typically find the peripheral nerve stimulator that you see a patient, either inpatient, outpatient?
Yeah. So I would start with, where all is the pain distributed? Okay. And more of the distal, like hands or feet, that are usually harder to get. And if it is not just, one specific pathology related that I can address, usually like peripheral neuropathy, or again, pain in 1 or 2 nerve distribution. If I have a patient like that, I would have tried my conservative medications and physical therapy, the usual things that I would try. And then after that, I would try a nerve block and see, because sometimes the nerve block itself, putting the local anesthetic and a little bit of steroid, can reset the pain signal such that it doesn't come back, and I get several months of pain relief. And if that's the case, great. I can repeat the nerve block every couple months. And the peripheral nerve stimulator comes in when I usually have the nerve block didn't last long enough, in which case I will try the peripheral nerve stimulator. Or the nerve block provided no relief, then that also tells me that maybe that's not the right target. And it still helps me in my peripheral nerve neuromodulation sort of thinking as to if I have to target that area, maybe I need to go higher up. Maybe the pathology is more distal to get that coverage. And that happens, often. So if I have somebody who's having leg pain or foot pain, and I did, let's say, a posterior tibial nerve block, and that didn't cover at all, then I know that I need to go higher up. And I wouldn't do a sciatic nerve block as my test block, because the patient will have a lot of weakness, but I could do a peripheral nerve stimulator there.
Do you always do a nerve block prior to a trial?
So, there's a lot of opinions on that. And then, we're trying to study, does it make a difference or not? I do tend to do a nerve block, because what I know is if the nerve block provided 0 relief, the chances of peripheral nerve stimulator working is a little bit low, although the mechanism is completely different.
Right, exactly.
The nerve block is completely blocking the signal. It's stopping the signal, so in general, I think of if nerve block couldn't provide any pain relief, modulating the signal probably has a little bit lower of a chances to provide some pain relief. So, and then I also always do very targeted, very low volume nerve blocks. So I always try to visualize the nerve. So when I place the electrode, I know exactly where I'm going for. So it's not a field stimulation, it's more targeted nerve stimulation. So if the nerve block does not provide any relief, I know that either that's not the right nerve or that is not the right level for me to target. Maybe I need to go somewhere else to target that pain. So I tend to do nerve block when I can. Now, when I have pain that I will not be able to cover without blocking a major nerve that has motor supply, those cases, either I talk to the patient, then, okay, I'm going to do this test nerve block. You'll be weak. You won't be able to weight bear, or you'll have to wear an arm sling. Or in those cases, if I have, clear indication of why that patient is hurting and then distribution, and we just want to go ahead with a peripheral nerve stimulator, we may do that. But in general, I'll say more than 80%, I do a nerve block first.
Makes sense. Yeah. And, nerves, since there's purely sensory nerves, there's purely motor nerves, there's mixed, there's parasympathetic, sympathetic nerves. Is there a nerve? Is there a joint? Is there a muscle that you see most commonly that you use this PNS system for?
So yes, so I love posterior tibial because it's and I target it in just above the ankle. Okay, because in that area is very superficial from the ankle if you trace it up. And I like to place my peripheral nerve stimulators parallel to the nerve each time if I am placing them, more so for permanent reasons, leaving them permanently in then. And the posterior tibial nerve supplies the bottom of the feet, and bottom of the feet is what's most painful in most peripheral neuropathies. So if the patient has predominantly bottom of the feet pain, it's really nice to capture. And those have been historically harder targets to capture with spinal cord stimulators or central neuromodulation system. So absolutely, I love it because, it's more distal, easy to capture. Usually people don't mind beating, things in the leg, and single nerve that captures majority of the pain.
That's nice. Yeah. I'm sure that's huge relief for the patients too. So just our other forms of management in pain therapy or pain management, I suppose, we have medications, we have physical therapy. How can you compare the two? I mean, I suppose it fits further down on the algorithm of management, but do you ever juxtapose, maybe using gabapentin with peripheral nerve stimulation? Do you ever compare those with patients, or do you have like what you could compare with physical therapy and peripheral nerve stimulators by chance?
So, how it fits together with other treatments that I have to offer. So usually that happens as part of the conversation with the patient. When the patient comes, it depends on how bad is the pain and how much is it interfering with their daily activities. And they're really suffering. If they're struggling to keep their job and they come to me in that, time frame, I would do multiple things because I know it's not going to be just one thing that's going to take all the pain away. And especially if the pain has been there for a long time. I will sometimes get lucky where I get somebody who has only had pain for 6 months or less than a year, then I know we have a high chance of maybe we'll be able to come to a complete pain-free state, Right. That's another reason, actually, I would be a little bit more aggressive if I catch them earlier in their pain treatment. The pain has been there for more than 3 months. They're struggling, but it's still early on. So I feel like, if we can sort of attack the pain with different angles, use the medications, use physical therapy, acupuncture, and interventions and put them all together, maybe, very soon we'll be almost all, pain gone. And that usually would happen, with the chemo-induced peripheral neuropathy. Those patients will come to see me sort of earlier on because they have a very and they had a very finite insult, and sometimes that insult may be gone or ongoing. So in those cases, I'll do them together. But otherwise, also if they're suffering, then I will present it all together and see this is what we'll do. And then, because usually I'm not able to get them in for a procedure right away, so I'll make a plan that you're going to start this gabapentin if they're not on that. This is how you're going to titrate up to this level. And if your pain is better by this time, you cancel the procedure. But if the pain is not better, then we're going to go ahead with that, sort of make this complex plan for over 3 months, come back and let's talk about what happened, with which one. So my goal is to get them to sort of at a somewhat functional level. Pain's not going to go away, but make it tolerable as quickly as we can get there. But again, it still takes time.
Absolutely. Go ahead.
Go ahead. No.
The post-op period, like post-surgical pain, whether it is chronic, whether it is acute, where do you see peripheral nerve stimulators fitting into that picture? Because I know that's kind of like one of the hot topics now. It's like, how acutely can you use these peripheral nerve stimulators?
So the 60-day temporary peripheral nerve stimulator is actually FDA approved for acute postoperative pain. And I do think that we're probably not using it enough, because we know that a lot of the surgeries can have up to 50% of post-surgical pain. That's pretty high. And we know somebody's going into surgery and that can be avoided and treated. We should be more aggressive about that, so that pain does not become chronic. So I think in that case, acute postoperative pain, I would still do a nerve block, because that we could do quickly. Probably try to, if that's the case, probably try to get them in for the nerve block the same day that I'm seeing them. And then if the relief is only for a day or two, it didn't go away, then come back for peripheral nerve stimulator pretty quickly in that case, and then do the 60-day temporary one, because hopefully that pain never becomes permanent.
Yeah, exactly. What potential risks, adverse effects do you see with peripheral nerve stimulators?
So it depends also on the type of system that you're using. But in general, I talk about the risk that is there with any time you put needle in the body, because with all of these peripheral nerve stimulators, you're putting a needle, then that is delivering the wire in a certain way. So you got infection, bleeding, and damage to nearby structures. Most of the time, I'm going away from the spine. So that in general is good. If there is damage that's more local, that's more distal. If there's infection, it's more local or distal. I've almost yet to see any infection with this. The biggest complication that happens is migration. So the lead moves because we're not cutting down and we're not sewing it to the nerve, for good reasons. So it can move, but it can easily be replaced as well if it does move. So that's the biggest complication, or the lead erosion. Again, you can plan for it fairly well and choose your target appropriately. You could minimize that. Theoretically, it's possible, but I'm not seeing that yet either.
The lead fracture and the dysesthesia, both of those, how often would you see either of those? You put the peripheral nerve stimulator in and maybe you get some pain relief from it, but also the patient may complain of, now it feels weird and I don't like that. Does that ever?
So I have not seen dysesthesia, because they're fairly, I would say non-irritating structures that you're placing. The fracture I've also not seen. So the key is to, whenever we're placing the peripheral nerve stimulators, you choose your target and how you're going to place it. Where is the tail going to go? Where is the electrode going to go? Very carefully, and study, you never to cross a joint. And then also kind of think of, okay, where you're placing it, if the lead would migrate, where all it can go. What I've seen is deeper migration of the leads. So fracture is theoretically possible, but we don't really see it because as long as you're planning it well and it's not in an area where it's just going to move a lot of crossing joints, in general, it stays well. Sometimes we would see that the tip of that 60-day temporary implant, sometimes when you're tugging it out, it may be left behind, just very, very, very tiny distal tip, which is smaller than a surgical staple. But you can do things where you can locate the peripheral nerve stimulator with, ultrasound, tug, and then inject local anesthetic and saline and hydrodissect that area. If that's happening when you are encountering resistance when you're pulling it out, and let it sit, wait a little bit, come back, wait a little bit, come back, and 99% of the time it'll come out.
Awesome. Yeah, it seems like preparation is key for everything. So as long as you prepare, trace out the nerve, ultrasound, know your landmarks, I think that's key. Speaking of which, how does the implantation process go? What do you tell patients about recovery thereafter?
So again, it depends on which system we're using. For the 60-day temporary device, that usually gives us a lot of leeway. The needle is about 12 centimeters long, and target could be anywhere from, half a centimeter, 1 centimeter to 12 centimeter. Usually we want to leave at least 2 to 4 centimeters in the body. So if the target is too close to the skin, I may just start a little bit away from the target so I can have a couple centimeters of the electrode under the skin. The 60-day temporary peripheral nerve stimulator doesn't hurt so much more than what the nerve block did. So I tell them that it's going to be actually very similar, but we do still want to implant that in a procedure room setting, more sterile, because we are placing something that will stay in the body for 60 days. So prefer to do it in a procedural area. The temporary device, the permanent devices that we have, many of them have trial options. I'll do trial when I can, unless there are strong reasons not to. So with the trial, again, it's simple because I don't have to plan where to bury the tail end of the electrode. I will put the lead still parallel, so somewhat still different because I still have to put about 8 to 10 centimeters of the electrode under the skin. And then there'll be a lot of taping. So I tell them for the trial, there'll be a lot of tape on your body. You'll not be able to take a shower for 5 to 7 days while the trial device is in. And that is usually the most sort of preparation that you'll not be able to take a shower for 7 days. It usually doesn't hurt. It's uncomfortable because yes, there is a wire in your body, but usually it doesn't hurt. For the permanent, it's I prepare them that there will be 1 or 2 incisions, but usually tiny, usually no more than an inch, and they don't really hurt. I inject quite a good amount of local anesthetic for all my procedures. And we do, there's no sutures to cut at the end. We'll do subcuticular sutures if need be. They go home, tell them to use ice the same day, make sure that it's covered in a towel, and so it's not leaking on the wound. And usually over-the-counter medications are enough because, again, we're not implanting the battery under the skin. Right. The battery is worn outside. I do tell them that we'll wait to, start using the device until the incisions have healed. So we're not causing just unnecessary energy going through those incision areas, and make sure that it heals before we use it. Usually 7 to 14 days is enough.
Okay, got it. What percentage of patients, and this is a difficult question because like you had mentioned, there are so many different devices, but what percentage of patients would you say go from a trial to a permanent implantation?
Very selective.
That's good.
So, usually I would say if I got pain relief with the nerve block, and I have clearly isolated the nerve, I'm taking a lot of time intra-op, making sure I'm on the nerve. It's not just field stimulation. Usually I'm also doing intra-op sensory stimulation unless it just looks fantastic. And we know that this patient has had fantastic results with the nerve block. And but I'm almost always doing intra-op stimulation. I'd say, about 80% who get the area of pain covered with the stimulation, they go to the permanent. It's just that not so much, I would say there's some cases of, like, for example, complex regional pain syndrome where pain appears to be limited to one or two nerve, but even though you're targeting that nerve, you don't get the relief because probably the mechanism is a little bit more central, and especially after they become more further along their course, it becomes more complex. So very rarely, as long as they have some sensation in the area of pain, because that nerve has to do the job of carrying the signal. So if the nerve is dead, what are you placing the electrode on? Right. So those are the things, if you take all of that into account, usually I've had good success rate.
And just speaking of that nerve block, what percentage of pain relief do you typically look for in the nerve block to proceed the trial for the PNS system? Do you look for a percentage of pain relief, or do they say, like it helped and you're just
I would say I like to see 80% or more. But if they've had 50% pain relief, then I would want to make sure, is it still the right nerve and the right target? And if they've had 50% pain relief, was it because there was an area of pain that was just not covered? So maybe there's another nerve that needs to be included in the treatment. Or maybe, again, that's not the right location to target. Maybe we need to be higher or somewhere else along that nerve pathway.
Fair enough. What do you typically see as getting in the way from conversion of trial to permanent, besides perhaps not targeting the right nerve? Maybe it's they just didn't like something in there, underneath their skin, or what do you typically see getting in the way of that conversion from trial to permanent? Usually
it would be lack of pain relief.
Okay. Yeah.
Almost always, if you have pain relief, the patient wants to go for that. As long as they know what to expect. Mm-hmm. There are some very unique, like, patient factors. You may just have one specific, where it's they just didn't like the feeling, but it's very, very rare, because you would have talked to them beforehand. What will it look like? I usually will show them pictures of what the stimulators look like, and I have other pictures of patients have given me permission to use, and non-identifying, like, this is what it looks like inside the body, outside the body. Mm-hmm. So a lot of times my patients who didn't want to do it, they would have already told me that I know this is not what I'm interested in. And if they've said that I'm not interested in, I have not offered that.
Is there anything, and I'll say, I had an attending that liked to pair Tylenol with Tramadol. And for whatever reason, he felt like that really helped pain relief much more than either separately. Is there anything you like to pair in conjunction with a PNS system, medication or PT wise, or anything that you feel like really knocks it out of the park every time?
I don't think I have discovered that magic combination. Okay. Maybe you can tell me when you start practicing, what is the magic combination?
Hopefully we can find something like that.
Yeah, but usually it's just the right target, waiting for it to heal, let it, because I also want it to scar in place so it doesn't migrate. And then, after that, if it is complex regional pain syndrome, then maybe we want to combine that. But usually I'm doing that with my nerve blocks, where I'm saying, okay, we're just doing the nerve blocks to allow you to participate in physical therapy. Gotcha. But maybe for acute post-surgical pain, there might be some role. Sure. We're just not doing enough of those. We need to be doing more.
Sure. What recent advances or innovations have you seen in peripheral nerve stimulation?
I think, I would say the one that we're seeing right now is fairly recent, in terms of the battery being externally located, and the internal pulse generator could be internal or external, the part that sends the signal and the programming. I believe there are multiple companies working on their own product and designing advances in terms of, if there needs to be different waveforms and frequencies specific for peripheral nerve stimulation. delivery mechanism. How do you place the lead on the nerve, making it more simple and more deployable. So those are probably coming down the pipeline. But the biggest one that we're seeing right now that has been is that battery is outside the body, and you only have to plan for placing your electrode. And then the 60-day temporary gives you a lot of options because it's a temporary device. It's not a permanent change.
The waveforms and frequencies, I suppose, could be a podcast in and of itself, but are there specific ones you use for specific nerves? Do they change? Or is that something you leave to the representative, the rep of the company?
So usually what I'm going for the permanent devices that are capable of doing it paresthesia free, so a little bit higher frequency that makes it paresthesia free, because feel like if I'm a patient, I want to feel nothing. I don't want to replace the pain signal with another signal. I just want to feel nothing.
Right.
So usually that's what I do with my permanent options. With the temporary device, you only have two options: the motor stimulation, the sensory stimulation.
Okay.
And depending on what my target was and where I placed them, 80% of the time is sensory stimulation. It's just the cases of where, okay, we're 30 days in and we have had zero pain relief. And depending on the type of pain we're thinking, depending on where we placed it, we may try motor stimulation temporarily to see if that's any better. And that's 12 hertz and 200 hertz.
Got it. Okay, 12 hertz, 200 hertz. And then just lastly, is there any success story or testimony that comes readily to mind for you that you've done a peripheral nerve stimulator for, helped the person out so much or gain their quality of life? Or is there anything that comes to mind that particularly maybe someone that didn't really have much hope prior to putting a peripheral nerve stimulator in?
Yeah, so certainly I'll share this this patient who had actually done a testimonial for the device as well. This was young patient, who was actually an exercise physiology or physical therapist, I believe, and had worse on the thenar eminence of the right hand, and so couldn't use the right hand because it would hurt. So it was very painful. He would always come to my office sort of tucked in, arm tucked in. And I started to take care of him kind of before the peripheral nerve stimulators were quite available. And we were trying the usual, the duloxetine, gabapentin, everything else that we can think of. We did all of that, CBT therapies. And he had started to, he was fairly, still young. And the peripheral nerve stimulators came out. So I started with median nerve block for him that gave him 80% pain relief for a day. So then I did the trial for him, same results. And then I did the permanent. And actually it was during the trial that he came to my office follow up and was in tears because he was like, I will shake hands with you today. And I have been cooking using this hand I chop. So it was just life-changing for him because you were able to use your right hand when you are right-handed. So, and there have been just certainly, so again, it just comes down to the proper patient selection and having the pain 1-2 nerve distribution. And getting, good results. So definitely it's been very rewarding. In general, I feel like as long as we can isolate the nerve, we get such good results with this.
Awesome. Well, with that, I think that's a good place to wrap it up. Thank you so much. I know you're extremely busy, so I really appreciate it.
Thank you. It's been fun.